Ngaon.
Dugo pang.
Dugay pa kayo. Nanong kaon gutom pamahaw.
Eh, si Gabi na pang pamanata.
Okay ra eh. Oo. Pangalan.
Okay. Good noon, everyone. So can you all hear me?
Afternoon, Doc.
Fernanda.
Afternoon, Doc.
Okay. May good to. Now I am here to talk and discuss to you about the common rheumatic conditions in children. I placed there apostrophe because rheumatic conditions are really not common in children, but I would just present to you the common of these rare conditions. Okay, so I hope you are all well today, and you're very stressed in your third year now. But I do hope that your BMI is not also getting higher because of this pandemic, and you're all in your room just studying, eating, and sleeping. Okay, so just get through third year now. If you're having a hard time, we are very much willing, and we welcome you if you want to go back to second year. Okay. So don't mind with the rest of the difficult exams that the third year faculty are giving you, because it will really give you an advantage when you go to the board examination, and you'll get your certification as a licensed physical physician. You know, because most of the comments of the premores, when they took the board exam, it was just like taking a bi-monthly exam. So that's how they get used to these exams in our system. You know, so just 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 study and just read and take the exams, and so you will be able to have that attitude, and you'll be ready when you go out and take the board exam. Now, going back to my lecture topic about the common rheumatic conditions in children. Okay. So pediatric rheumatology is a growing subspecialty. It is one of the challenging and mind-stimulating subspecialties. It's like a puzzle, filling in the pieces to solve a mystery. Now, up to this point, if you read the book and journals, some or most of the rheumatic conditions are still unclear. The cause, the spectrum, etc., even the diagnosis, making it very complex and difficult. Thus, we have this referral, and sometimes we are at the end of the referral because most of these patients are going already to different doctors. They're already hopping to different doctors just to get their child treated, because it's difficult, it's complicated, and most of the physicians are not well exposed to this kind of connective tissue disease. So because of that, we feel like we are Dr. House. So if you have watched Dr. House before, this was a very popular series during our times. In fact, during our board exam, it was kind of funny. Most of my classmates were saying, "Oh, you watch Dr. House because it will help you in the board exam." Because it talks about diagnosis, how to approach a patient with a certain kind of manifestation, something like that. Because in pediatric rheumatology or in rheumatology in general, as long as we already get the diagnosis, the management is basically the same. We give patients with immunosuppressant drugs, but the difficult thing in our specialty is how to arrive at the diagnosis. That is why it's really very important for us to have that thorough history and physical examination. In fact, when I have a patient in my clinic referred to me for evaluation of a rheumatic condition, I always take like 1 hour or more just to have that complete history and physical examination. Okay. So it is sometimes considered a gray area of medicine because there are few useful diagnostic tests, there are few pathognomonic clinical signs, and the therapy often lacks specificity. So in fact, in a survey, out of 683 general pediatricians that were surveyed during 2002 to 2006 who were between 1 to 5 years post-residency training program, 21% reported that they were uncomfortable participating in rheumatology care. Because if you can notice, or during our time, we don't have a rheumatology um, 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 discussion or lecture. So that's when I get into the fellowship training program in UP, and I realized that those conditions that I learned during the fellowship was really not discussed during my medical years. And in fact, it was I can't even remember studying one. So when I get back from the training, I went back to CIM and I volunteered to the dean. I will teach rheumatology, pediatric rheumatology. So it was one of my advocacies that when I go back to Cebu, I'll be teaching rheumatology to all the medical students in Cebu City, because I realized that it was not really that, it was not taught to us. And in fact, that's why there are a lot of doctors who are really not comfortable um, seeing patients with musculoskeletal manifestations or symptoms suggestive that it might be connective tissue or autoimmune disease, because they're not really very confident of, of diagnosing or even treating. And in fact, there are also a lot of patients who are referred to us who are not even rheumatologic in nature, because there's some some form of like um, how do I say that, um, this they don't know how to distinguish between rheumatologic and non-rheumatologic condition. So that is why when I came back from training, I said to myself, I have to teach these medical students so that when they go out and they will have their practice, it will no longer be a problem with the referral system, with the early diagnosis and the early treatment. Okay. So this is a list of the classification of patients seen in pediatric rheumatology in the ambulatory clinic. So if you can notice, the juvenile idiopathic arthritis is the highest among the pediatric rheuma conditions, followed by non-rheuma, orthopedic and mechanical, connective tissue diseases, vasculitis, non-rheumatic, those even with unclear diagnosis, uveitis, pain syndromes, and autoinflammatory disease. So this is the research I made during my fellowship training, wherein I found out that in the Philippines, the most common connective tissue disease we have is systemic lupus erythematosus, as compared to the other countries wherein juvenile idiopathic arthritis was the most common. I realized maybe because Philippines is a tropical country, and we know for a fact, or I don't know if you know it, that sunlight exposure is a very it is a very triggering factor for flare up of SLE. So actually, most of my patients are flared up during summer times because of increased exposure to sunlight, and most of these patients are actually kind of wants to go to the beach and go out and spend vacation outside. So there is really the risk of exposing themselves from the sunlight, and thus they will have the flare up. And then followed the SLE is the arthritis, the Henoch-Schönlein line, rheumatic fever, Kawasaki disease, polyarthritis nodosa, and unclassified vasculitis. Now, you may notice that these actually conditions are very foreign, no? It's not every day that we see this kind of conditions, but I think it is very important for you to know that we should also study this kind of conditions because it might be rare, but we can see them siguro one point in your lifetime. So it would be better for you to early recognize this kind of conditions. In fact, when I studied before in pediatrics, I skipped the Rheuma chapter because I thought to myself that these conditions are not found in the Philippines. The names of the conditions are so foreign to me. But when I realized, when I had the training, I really see this kind of patients, and it's really very good to help the parents, wherein sometimes they come to you very desperate already because they don't know what's happening to their child, and then you give them the diagnosis. So murag na ay kanang closure ba of the dilemma. Okay. So the objectives for this afternoon is I will discuss on how to evaluate a child with a suspected rheumatic diseases, how to evaluate a child with musculoskeletal symptoms. I will illustrate the PGALs. I don't know if you have taken this up during your PD under musculoskeletal, but I will show it to you again. And then I will show you different abnormalities of the joints in the musculoskeletal and illustrate some common rheumatic conditions in the local setting. And I will discuss on pediatric SLE. Now, it's very unfortunate that I only have like 2-3 hours of rheumatology lecture, but if you see in your book, there are a lot of chapters under rheumatology. So I cannot discuss all of them to you right now, but I do encourage that you read them in your book. As much as I want to talk to you and share my knowledge to you about rheumatology conditions, but I don't have the luxury of time to do it. So I would encourage and advise you to read it in Nelson's. If you want, we can have a one-on-one session if you want to. Okay. Now, before anything else, I've been teaching this to most medical students that there are 4 models of medical problem solving. We have algorithmic, the hypothetical-deductive, the exhaustive, and the pattern recognition. Now, we know that arriving at a diagnosis takes a long process using the history, the PE, and the laboratory to identify the disease responsible for the patient and make a decision about the treatment. Now, here in the models for medical problem solving, I have enumerated 4. So when you say algorithmic, it means to say that you have a certain condition or a certain manifestation, and then there is an algorithm on how to arrive at a diagnosis. So just like the one you are seeing in your Harrison's. Say, for example, a patient has fever, and then there is an algorithm on how to go about it. But so that's the algorithmic type of medical problem solving. Now, hypothetical deductive is the one actually that we are using, but we just don't know that it's the term. It's hypothetical deductive. It means the rule in, rule out. So just to explain briefly, say for example, if you have a patient with fever, so you have differential diagnosis in mind, but when you extracted the history and the fever is associated with cough, then you narrow down your diagnosis. So you are therefore ruling in and ruling out the impressions. And the next type is the exhaustive type. So exhaustive type is you order every test you think that might give you the information the patient's condition. The downside of this exhaustive model for medical problem solving is that you be asking the patient to spend a lot for the laboratory test just to give you the right answer and the right the abnormal laboratory results. And it's also, aside from it's costly, it's also time consuming, and it doesn't require you to think already because you're only relying on what would be the abnormal or the abnormal laboratory results. The one thing that we rheumatologists use is the pattern recognition. So it is an instant recognition of a disease based on patterns or classification criteria. So if you've noticed in your Harrison's, I don't know if you have adult rheumatology lectures already, there are conditions are actually based on classification criteria or diagnostic criteria. Say, for example, SLE, we have a criteria for that, Kawasaki disease criteria for that. So everything actually is based on classification criteria. So there is a pattern for each condition. So that is why it really takes time for you to see and be what you call that to learn how to diagnose patients with rheumatic conditions. So if you see a lot of those conditions or exposed to a lot of this, so you get it would be easier for you. When I came back from training, because it was really taught to us how to be meticulous with the history and physical examinations from head to foot, because there are the physical examination findings of this condition should be inspected from head to foot. So when one time I went to Ayala, and during my training, so I was kind of very how do I describe it? Basta when I see patients, when I see people in Ayala and I see their rashes, or I don't know, there's something in their hair, there are already a lot of differential diagnoses that I have in mind. So that's how I was during the time that I came back from training, because you have to think of all the possibilities that this patient is having. Sometimes we do think that manifestations or the manifestations or the presentations of the patient might be just like a normal thing. So we might disregard this kind of simple or little or few manifestations, but for us, we do consider it, and then we think of different we think of possible conditions that might have this kind of manifestation, even for a single rash, or even if your hair is thin, and you might think that it's normal because my parents or my parents' hair is like this one, or even if the color of your nails, we do have a lot of differential diagnosis for that. So when I going back to my story, when I went to Ayala, so it's like I'm scanning the person, especially when I see a rash. And then I told my husband, maybe that patient is having a psoriatic or a psoriasis. So that's how I was before, and it's really very it's still what I do right now, but I don't I just keep it to myself because I don't want other people to be afraid of me because I will be diagnosing them. Okay, so yeah, we're doing the pattern recognition. So kung sa Tagalog pa, in English, Tagalog ay our usual expression is kana ganing naaamoy na namin siya. So like if we see a patient just coming into our clinic and then kanang masimhot na namo, like kini siya lupus ni siya or kini siya na ni siya inani. So that's how kanang we see it, and then because of the pattern recognition. So I'm not using, and I will not be scanning you when we see face to face, no, in the future. So that's my promise. Okay. Okay. So rheumatic diseases are a constellation of signs or symptoms. It is it is results of physical examination, autoimmune marker, serologic test, tissue pathology, and imaging. Now, okay. So the recognition of clinical patterns remains essential for diagnosis because there is no single diagnostic test in rheumatologic conditions. And there is evolution of symptoms over time. So this is really I would like to emphasize that the evolution of symptoms over time, because the symptoms of a rheumatic condition will not come all at once. So I have a patient wherein I diagnosed with SLE, and I saw her like she was an adolescent, and she presented with arthritis, but I advised the mother to clinically monitor the patient because there is a strong family history of SLE. And in fact, her aunt died of SLE at the age of 14 years old. So they were kind of scared that the patient will have the same incident of um, dying at a young age. So during that time, I did not diagnose the patient as having SLE yet because I only have arthritis during that time. So I asked the mother to just monitor the patient. So after 2 years, true enough, the patient developed um, evolutions, symptoms evolved, and there were additional symptoms that occurred. Patient had alopecia, fever, and then when I checked the CBC, there were already signs suggestive of SLE. So I worked up the patient for SLE, and the patient was positive for SLE. So that's how symptoms evolve over time in autoimmune diseases. So sometimes it takes years before other symptoms will appear. And to add to the difficulty of diagnosing a rheumatic condition, there are also a lot of minicurves of rheumatic diseases. These are infection, malignancy, metabolic, orthopedic, and chronic pain conditions. The exclusion of possible mimicking disorders is essential before initiation of treatment for a presumptive diagnosis, especially corticosteroids. Why? Because corticosteroid exposure prior to the ALL, acute lymphoblastic leukemia diagnosis, which sometimes is the initial presentation of patients with malignancy, especially ALL. So the exposure, or if you're going to treat a patient with steroids, especially if the patient is presenting with arthritis, but it turned out leukemia, but because you did not work up the patient really well. So the exposure of corticosteroids will adversely affect the prognosis of the patient with malignancy, because it will mask the otherwise high-risk features of malignancy, such as elevated WBC, or alternatively, it will result in a partial response, and it will also promote a disease resistance. So that is why you have to rule out other possible mimicking disorders before you initiate treatment. Now, what are the symptoms suggestive of rheumatic condition? First, let's talk about arthalgia. These are the common symptom in childhood, and it's the frequent reason for referral to pediatric rheumatologists. So when you say arthalgia, it is a subjective complaint, right? Because it is a symptom. So it means to say there is joint pain, but there is no physical findings for arthritis. So because it is already a physical finding and you're examining it, it becomes an objective finding. So which means it becomes arthritis, okay? The next is fatigue. So fatigue is a non-specific symptom. It is a common presenting complaint in patients with juvenile dermatomyositis, but it can also be seen in patients with SLE, vasculitis, and other chronic childhood arthritis. Okay, so fatigue. And the next symptom is myalgia. It means muscle pain. So it is it is pain in the muscle. So it becomes an objective finding, it becomes myositis. So myalgia is a subjective complaint. Okay, so this is found in your book. This is just a table showing the signs suggestive of rheumatic disease. So there are tables showing you the possible rheumatic diseases and the possible non-rheumatic diseases. So these are just FYI. How about the signs of rheumatic diseases? Many rheumatic diseases have multi-system effects, and a complete physical examination is mandated in any child in whom a rheumatic disease is suspected. So this is also found in your book. So I would just like to point out the important ones. Okay. Now, there are only two rheumatic diseases that presents with malar rash. We have SLE and JDM. But how are they differentiated from each other? Their SLE spares your nasolabial folds. And there are also non-rheumatic causes that will present with malar rash. One of these is sunburn. Another is parvovirus B19. We know because parvovirus B19 is the slap cheek disease, if you can remember, and also Kawasaki disease. Also, we know that it's called a malar rash, if you can remember, because the rash is distributed along the malar eminences of the face. Some people will call it a butterfly rash. Okay. Now, another important thing to remember in this table also is the oral ulcers. Now, there are two rheumatic diseases that presents with oral ulcers. We have SLE and Behçet's disease. Have you heard of Behçet's? So Behçet's is a condition found mostly in the Mediterranean. So if you know one, maybe they have a blood of that descent. So Behçet is an autoinflammatory disease that presents with recurrent oral ulcers, genital ulcers, and uveitis. Okay. Another important to remember in this table is the Gottron papules. This is only found in patients with juvenile dermatomyositis. In fact, this is a pathognomonic sign of your JDM. I'll show you pictures later. Okay. Now, this is a patient of mine with juvenile dermatomyositis. The rashes is called the Shoal sign because the distribution of the rash is like one who is wearing a shawl. So it distributes in the anterior chest, in the upper back, and you can see it also in the deltoid area. Okay, so this is called a Shoal sign. Okay, part of being a rheumatologist also is having a keen eye. So if you see something like this, you would not suspect a patient to have JDM. Okay, so if you see this one, this is actually the Gottron papules that you see in juvenile dermatomyositis. Sometimes you will disregard this as a paternity finding because there are also a lot of patients we have dry skin. So kung ikaw dili kay ka meticulous, you will just say na ay basig dry ra niyang skin or gawan lang gyud ni siya iyang panit, no? But if you look it closely, it is actually a scaly erythematous rashes. And these rashes are also found on the elbows and the knees and your MCPs and your PIPs and your DIPs. Now, these are Gottron papules that we see in patients with JDM, and these are pathognomonic rashes. Previously, I also mentioned that there are only two rheumatic diseases with malar rash. So this is the same patient with the malar rash. So the malar rash of both JDM and SLE are photosensitive, meaning to say when they are exposed to the sun, they will develop that rash. And it spares the nasal labial folds if it's SLE, while in JDM, it is a diffuse facial rash. Okay. Now, this is also a picture showing the oral ulcer of SLE. Now, remember that if you do a physical examination, sometimes you have to look at it than just asking the patient because, say, for example, this oral lesion in SLE, these are painless. So the patient will not volunteer that I have this kind of of kanang oral lesion. So you have to look for it. It is actually mostly found in the hard palate of the patient. Okay, so these are found in patients with SLE. Okay, now another is this one is your heliotrope rash. So heliotrope rash is the violet or bluish purple rash that develops on areas of the skin. This is another pathognomonic sign of JDM. So this is here, the heliotrope rash. It's like you are wearing an eyeshadow. Sometimes people will say that you're wearing makeup, but this is a rash of JDM. Okay. Another rash of JDM is the calcinosis cutis. This is actually accumulation of calcium salt crystals that is seen in long-standing uncontrolled JDM. Okay, so this is actually very painful. I see this kind of skin lesions, and then it indicates a more chronic, uncontrolled activity of JDM. It's like a stone protruding or coming out from your skin. So it's really very painful. Okay, so we also see these patients with digital gangrene. So this is seen in any vasculitis with compromised supply to the affected area. And we also have that one condition wherein the patients will have auto amputation because of the necrosis of the affected area. This one is a vasculitis. These are palpable purpuric rash on the extensor surfaces of the lower extremities. I don't know if you have seen a patient with Henoch-Schwann line purpura. Now, Henoch-Schwann line purpura is now replaced by the term IgA vasculitis. So you don't no longer use the term HSP or Henoch-Schwann line purpura because the newer term for that is your IgA vasculitis. Okay. Okay, so patients with arthritis will also have this arthritis and flexion contractures. So I don't know if you have grandmothers who have rheumatoid arthritis. This will have the most debilitating joint abnormality. So they will have these contractures. Okay, so this is a rash of a patient with systemic onset juvenile idiopathic arthritis. These are spotty, pale red or pinkish salmon-colored evanescent rash. It rarely occurs on the face. It typically appears on the chest, the upper arms, the upper thighs, although it can also be found in other parts of the body. Now, there are no specific screening tests for rheumatic disease. So you have the appropriate testing and workup is directed by the differential diagnosis. So this table shows the antibody test and the associated rheumatic disease. Let me emphasize on the conditions we see in practice. First is the ANA. The ANA test result is also positive in up to 80% of children who are normal. So some journals even mention 20%. And the levels of ANAs increase in those with a first-degree relative with a known rheumatic disease. So very important that we don't just order ANA left and right, because I always kind of teach my students that you should order for something that you anticipated the results. So if you're going to request for a lab, you should be able to know what you are requesting, or else you will just fall into a diagnostic trap. So say, for example, you have a patient referred to you for a joint pain, and you just requested ANA because you don't know what's the diagnosis. I'll just get ANA because this is a test for autoimmune disease. So if the patient comes to you and then the ANA turns positive, how will you explain it to the patient? No? So do not order for something you don't know. Do not order for something that you don't have an impression in mind. So aside from it's costly, it costs like 2,500. You will fall into a diagnostic trap. How will you be able to explain it to the patient if the patient will ask you what the result is, the interpretation of the result? Because I do have a lot of referrals from other doctors wherein the patient is came to them for joint pains and then they request for ESR or ANA. But since the the laboratories are abnormal, so they will refer the patient to me and I will do the explaining to them, which I did not order in the first place. So can you imagine the burden that I am doing by explaining to them that the test that I didn't even request. So you have to have that reason why you are ordering such laboratory tests. And then sometimes I also do have patients who came to me crying already because the other doctor is requesting them for ANA for some other reasons and the ANA turned out positive. And so because parents nowadays are very techy and then they Google everything. So when you see and Google it in the internet, you will really see that ANA positive is associated with SLE, these kids will die, they will have a poor prognosis. So when they come to me the next day and then they show to me the result, and I told them that it's nothing, it's just normal because we also see that in 30% of the time na children who are also normal, so they will really be relieved and kanang and they will kanang open up na, you know what, doc, last night we almost have a fight with my husband because of this one. I cannot sleep, doc, because I'm crying all the time because I'm afraid that my patient or my kid has this SLE. So you're trying to cause anxiety to the parents, which you don't know actually what you are requesting about. So the burden of me explaining it to them without that I'm not in fact requesting for it. So hi good siya, and then I receive this kind of parents who are already on the height of their emotions, crying because they're afraid their patients have SLE when in fact there's nothing to worry about. No? Okay. And then double-stranded dsDNA is specific for SLE, but important to note that it's not sensitive. The test is not so sensitive. It only detects positivity in 60 to 70% of the time. And your anti-SNP also is also specific for SLE, but it's not sensitive test. It only detects positivity in 20 to 30% of the time. Okay. Okay, so this is just a continuation of the diagnostic test. You will be encountering these autoantibodies when you read the conditions one by one. Okay? Now, I would just also like to tell you that kids get arthritis too. So how do we evaluate a patient with joint pains? Now, musculoskeletal symptoms can be a presenting features of juvenile idiopathic arthritis, malignancy, infection, vasculitis, or even non-accidental injury. It is therefore important that all clinicians to whom musculoskeletal problems may present have the necessary skills to effectively triage patients. So how do we evaluate them? One of the challenges of rheumatology is the early recognition of a suspected rheumatic disease. And this is actually compounded as well by the lack of knowledge and decreased awareness of the parents, the relatives, and the patient themselves. So I will be pointing out today the important points and clues on the diagnosis when the patient presents with such symptoms. But first, let me introduce to you a rheumatologic history. Okay. So determining if a condition is inflammatory is generally the first step by your rheumatologic history. So inflammation is characterized, I know you know this in patho, inflammation is characterized by pain, warmth, redness, swelling, and limitation of function. So morning stiffness and gelling, especially after a long car ride, they are important indicators of inflammation. That is why if you have parents or grandparents who have rheumatoid arthritis, the pain is most severe during the morning because of this morning stiffness. And then family history, by asking the genetic basis, takes an important or an increased importance also. Because if you have a patient with a suspected rheumatic disease, most of them will have a family history or an aunt diagnosed with an autoimmune disease. It might be the same autoimmune disease, but there is an autoimmune disease in the family. But there are also times that it occurs sporadically. Social history is also very important, especially in children with amplified musculoskeletal pain and those with chronic conditions, which will have impact on the family and social function. And important also to note if there are problems at hand, like new life events, parents are divorcing, you are moving your house, or there are school changes, you transferred, or you failed a subject, or if there are family member changes, you have a new brother, a new sister, or you have a stepdad or stepmom, or any change in grade in school and school performance. Why is this? Because I'm talking about SLE because we know that stress would trigger an attack of systemic lupus erythematosus. I have a patient who is diagnosed with SLE, and every time exams come, she will really have this flare up. So mag-rashes na siya sa face, and then she will have fever. So we know what to do. Every time she will have the exam, and we will just increase the dose of the prednisone because exams, which are stressors, could really cause a flare up of the disease. Okay, so I have also a patient whom I diagnosed after the Yolanda typhoon. So that adolescent child came to me from Leyte because of alopecia, fever, and I think she had seizure. And then when I saw the patient, because I know the pattern already, nasinghot na nako siya, I really diagnosed her with SLE because of the stressful event, and then the symptoms came out. And then also another patient of mine wherein the symptoms came when her close grandmother died. So during the wake, the patient developed the symptoms. So things like that. You have to ask about stressors in the family or stressors in the life of that patient. That is why I always tell my patients na do not be too stressed about anything. Life is so simple. You have to be happy all the time. So dapat chill ra gyud, dili kay magproblema. Wag yun akong fan because I know that stress will really trigger an attack, and I don't want to handle those kinds of attack, and sometimes it's really very complicated. So and most of my patients are actually very competitive. They do well in their academics. So ganahan sila kanang top gyapon sa class and so on. But I do tell them that kanang your medical condition is really very important. So dili na lang kayo ta mo set of standard for ourselves because it will really give you that stress, and we don't want you to be kanang addicted because of that. So mura gyud na akong advice sa akong patients, dapat chill lang gyud all the time, no? Okay. Now, the key pieces of information about the problem can be captured with just few questions. You ask about the quality. Is the joint pain sharp or dull? The duration of the pain, the length of time, how long has the pain been going on, and how did it start? The development over time, is it getting better or getting worse? And the factors that affect the symptom severity. What lessens the pain or what makes it worse? Now, the problem with younger children because they cannot verbalize their complaint. So there are clues wherein we can say that this patient is suffering from a musculoskeletal problem. Patient is limping, there is a delay in the major motor milestone. Patients will revert to the infantile patterns of movement. They are irritable, they have poor sleep, they assume a posture of guarding the joints, they have decreased ability or interest in activities, and refusal to use a limb. Now, we have this SpeedGal. SpeedGal stands for Pediatric Gait, Arms, Legs, and Spine Assessment. I don't know if you have tackled this one during your PD. This is an evidence-based approach to a basic pediatric musculoskeletal assessment, and this aims to those who are non-specialists in the pediatric musculoskeletal medicine to discern normal from the abnormal. So this is a simple and quick easy to perform screening assessment tool. And as a screening tool, it aims to ascertain whether the child's musculoskeletal system is normal or not, or does it needs to be followed by a more detailed joint examination. But before we start with doing the Peegel's maneuvers, there are three screening questions that we have to ask first. Number one, do you have any pain or stiffness in your joints, muscles, or back? Do you have any difficulty getting yourself dressed without any help? Or do you have any difficulty going up and down the stairs? Now, if there are yes answers to these questions, then you move on to the SpeedGal exam. Now, this is just to show you a picture, but later I will give you the video. Okay, so this one is observing the child standing from front, back, and sides. This will evaluate the posture and the habitus, the skin rashes like psoriasis, if there is deformity like leg length inequality, leg alignment, scoliosis, swelling, muscle wasting, or flat feet. And then you ask the child to walk on heels and on tiptoes to assess on the ankle, subtalar, metatarsal, small joints of the feet and toes, and the foot posture. And then you ask the child to hold the hands out in front of you to check for the forward flexion of the shoulders, elbow extension, wrist extension, and extension of the small joints and fingers. And then you turn the hands over and make a fist to assess for the wrist supination, elbow supination, and flexion of the small fingers. And then put your index finger and thumb together. So this is to check for the manual dexterity and coordination of the small hands. And then touch the tips of the fingers to again check for the coordination of the joints of fingers and thumbs. And then you squeeze the metacarpophalangeal joints to check for the MCP joints. And then you ask the patient to put the hands together, palm to palm and back to back. This is to assess the extension of the small joints of the fingers, the wrist extension, and the elbow flexion. And then you ask the patient to reach up and touch the sky and look at the ceiling. It is to assess the elbow extension, the wrist extension, shoulder abduction, and the neck extension. And then you ask the patient to put the hands behind the neck. This is to check for the shoulder abduction, external rotation of the shoulders, and elbow flexion. And then try to let the patient touch the shoulder with the ear to check for cervical spine lateral flexion. And then open wide and put 3 fingers in the mouth to check for your TMJ joint. And then you feel for effusion at the knee by doing a patellar tap. So this will check for knee effusion. And then you ask or do an active movement of the knees, flexion and extension, and feel for crepitus. This is to assess for your knee flexion and knee extension. And then you do a passive movement of the hip to 90 degrees and internal rotation of the hip to assess for the hip flexion and internal rotation. And you ask the patient to bend forwards. This is to check for the thoracolumbar spine and check for scoliosis. So this is the video. Let us watch. So this is to summarize everything that I just said. So you observe the patient walking. And then you ask the patient to walk on heels and walk on tiptoes. And then you ask the patient to put the hand in front of you and make a hand over and make a fist. Touch the tips of the fingers to check for the coordination. And then you squeeze the MCP joints. Then you ask the patient to put the hands and wrists together, back palm to palm and back to back. And then reach up as far as you can, and then look at the ceiling. And then put the hands behind the neck. So reach the shoulder with your ear to check for the lateral cervical flexion. And then ask the patients to put 3 fingers inside the mouth to check for the TMJ. And then feel for effusion by doing a patellar tap. And then do ankle up to the bottom. And then passive movement of the hip and knee. And then you check the curvature of the spine from side and behind. And then ask the patient to bend forward to check for the thoracolumbar spine and check for scoliosis. Now, adults also have the galls. So what is the difference between the two? So it's the same as adult galls, but the pediatric galls has the following additions: the walking on heels and the walking on tiptoes. It is not found in adult galls. And then the hand and wrist together, palm to palm and back to back. And then reaching up the sky and looking at the ceiling. And the putting of 3 fingers inside the mouth to check for the TMJ joint. So those are the additional maneuvers in the pediatric dogs as compared to the adult dogs. Now, say for example, you have this kid came to us with a left knee swelling. So how do we report our findings? So these are the screening questions: any pain, left knee, problems with dressing, no difficulty, problems with walking, some difficulty in walking. So you tabulate the gait, arms, legs, and spine. So appearance, there is a problem with movement in the gait, appearance none, arms, no problem with appearance and movement, legs, there is problem with appearance and movement, spine none. Okay, so this is how we report, and then we proceed with the detailed joint examination of the affected joint. So when do we perform PGALs? So if the child is unwell with pyrexia, if the child is limping, there is a delay or regression of motor milestone, or if the patient has a chronic disease with a known association of musculoskeletal presentations, say for example, inflammatory bowel disease, because some of these patients will have arthritis, or psoriasis, because most of these patients will have psoriatic arthritis. Or if the clumsy child, if the child is clumsy in the absence of a neurologic disease. Okay, so when inflammatory joint is suspected, the lack of reported pain does not exclude arthritis. So there is a need to probe for symptoms such as gelling, like stiffness after long car rides, or if there is altered function like play, handwriting skills, writing, regression of milestones, or even deterioration in behavior, like patient is irritable and has poor sleep. Because there is a need to examine all joints, as often joint involvement may be asymptomatic. But in order to assess a child presenting with musculoskeletal features, the observer using the PGALs requires knowledge of the normal development, normal variants, patterns of pathologies at different ages. So you have to know the normal motor major milestone. So this is just to show you the normal major motor milestones. I don't know if you have developmental pediatrics already, but I will just point out to you this one. So sits without support is achieved by 6 to 8 months. Creeps on hands and knees is achieved by 9 to 11 months. Cruises 11 to 12 months. Climbing up the stairs on hands and knees is approximately 15 months. Run stiffly is approximately 16 months. Walking down the steps is achieved the longest at 2 years old. Walking up the steps on alternate feet is 3 years. Hopping on one foot is 4 years. Skipping 5 years. And balance on one foot for 20 seconds is 6 to 7 years. Okay. Now, this is a slide showing you the normal variance in gait and leg alignment. So this one is a bow leg or the genovirus. These are common from birth to early toddler and may resolve by 18 months, because some parents would actually be concerned about this kind of posture or this kind of legs. So sometimes they would let hilot this one, so para kuno mas straight. Now, important to note that this is really normal from birth to early toddler, and this will resolve by 18 months. After this one is we will have the knock-knee or the genovalgus. These are common, and this resolves by age of 7 years old. So some parents would be concerned about kimpi kuno ilang anak, no? But if it's still 7 years old and below, it's still normal. And another one is the flat feet. So flat feet, most children have a flexible foot with normal arc on tiptoeing, and this resolves by 6 years old. Okay, but beyond that, it becomes a problem. And then the last one is the crooked toes. This resolves when the patient is already on weight-bearing activities like walking. So it will not be crooked anymore. Okay, now this is just to show you a table that to make it easier for you, we have categorized the musculoskeletal pain into diffuse, local, and if the child is well, and if the child is systematically unwell. So for localized pains, we have growing pains, mechanical knee pains, strains and sprains, bone tumors, and spondyloarthropathy. For diffuse pain, it is associated with septic arthritis or arthritis of the joints, inflammation of the joints or infection of the joints, and osteomyelitis, which is infection of the bone. If the child appears well, think of hypermobility joint syndrome and fibromyalgia. And if the child is systematically unwell, you think of leukemia, neuroblastoma, systemic onset GIA, polyarticular GIA, oligoarticular GIA, and SLE. So what are the red flags to raise concern, whether it could be infection, malignancy, or non-accidental injury? If the patient appears with fever, with systemic upset, or lymphadenopathy, or hepatosplenomegaly, bone pain, persistent night waking, or if there is incongruence between the history, presentation, and the pattern of physical findings. The joint examination is probably the hardest to master. Careful attention should be given to each joint, and each joint should be felt for swelling or warmth. Rapid joint movement will elicit guarding as an early sign of inflammation. So your TMG can be destroyed painlessly. So close attention should be given to the jaw excursion. So this should be the ideal one, and any deviation should be investigated. So the tooth-to-tooth gap should be at least the width of the child's index, middle, and ring fingers held together. Elbows are best felt by holding the arm from the medial side and palpating just lateral to the olecranon as you extend the elbow. The enthesis is where the tendons attach to the bone. So the sites that are the most commonly involved enthesis in enthesitis-related arthritis are shown in the arrows. So this is enthesitis. Now, aside from those physical examination, there are also skin rashes or other exams that are associated with other rheumatic disease. So can anyone describe this one? And if you have a disease in mind, can you tell me? Are you done with derma? Can you just describe how it is in the picture?
Erythematous border duct with blanched center. Rash.
Okay. Okay, who is this?
Fear that.
Okay. Okay, thank you. So there is a pale center with erythematous border. So this is actually erythema marginatum. So from the word itself, there is erythema in the margin. We see this in patients with rheumatic fever. Okay. This one is, who can describe this one?
Nodules, doc. Subcutaneous nodules.
Okay, very good. So subcutaneous nodules, these are painless, firm collections of collagen fibers over the bones or tendons. These are found also in patients with rheumatic fever. How about this one? Is there a problem with this picture? Does it look normal to you?
No, doc.
What do you think is the problem here?
Edema, doc.
Again, sorry.
Edema.
Where? In the fourth? Fourth toe? This one.
Yes, doc.
Okay. So this is actually a sausage digiting. It's a dactylitis. You see in patients with psoriasis. Okay. So this is a sausage digiting. This one is, can someone describe this to me?
Elephantiasis. Doc.
Elephantiasis.
LLD, doc.
What's that?
Leg length discrepancy.
Leg length discrepancy. How do you know there is discrepancy? Who am I talking to? Please
Hold on.
identify yourself. I cannot see the chat box or the.
Si Gerald, doc.
Oh, sige. Leg length discrepancy. So how do you know that there is a discrepancy?
Assuming standing upright, one knee is bent, so it looks like it's longer.
That we do not know, no, because we have to measure. Okay, so it might be, but for this child, this is still toddler. I don't think this discrepancy will even be will appear at early as this age. Okay, so you might be right if you will measure both the legs. But aside from that, what do you see? It is not elephantiasis, no? You see there is already swelling of the left knee. Okay, no? So, dako lang gid kayo ni iyang left knee.
Joint effusion, doc.
Yes, it could be joint effusion. And there is also the limitation of knee extension. Okay, let's start with the upper left of your screen. So, can anyone describe the picture?
Banding on the digits, doc. There appears to be bands on the
Which one?
Right,
Left,
right hand
right,
second
and
digit.
then
Also on
second,
the third, and also on the fourth and fifth. The
fourth,
right hand.
and fifth of left hand. This one?
Of the right hand, doc.
This one?
Yes.
Okay. What else? Thank you. What else?
Tapering of the digits as well.
Tapering.
Of the third and the third digits of both hands.
Third digit, this one? This one? Are you referring to this one?
Yes, Doc.
So there is what?
Looks like the finger is tapering.
Tapering, it's slender.
Yes, slender.
Are you referring to its slender?
Yes.
Okay. Aside from that, so there is slendering and flexion of the fifth and fourth and fifth and fourth. What else?
Different length, Doc.
There is also different lengths of the fingers. Now, this is what we call the brachydactyly. So, brachydactyly is the shortening of the affected fingers or joints because of the inflammation. Okay. So, initially, when you have a joint inflammation, the bone tends to grow faster because of the inflammation. But it also terminates the growth plate early. So at the end, it will appear shorter. Okay, so this is what we call the brachydactyly. Okay, how about this picture on the lower left? Is this normal? Normal, Nisha?
No, Doc.
So there is edema where?
And the thumb.
Thumb, this one? All the digits? Okay. So it is not edema, that's the term, no, there is swelling. So swelling of your, this one is your PIPs, proximal interphalangeal joints. And maybe there is also swelling of the MCPs. So this is a patient with arthritis. This one on the right side,
There are lesions, Doc, on the third digits of both hands.
okay, there is ulcers. How about the skin? Is it normal?
No, Doc.
Hmm?
Shiny, Doc.
It's shiny. What else?
Dry, Doc.
It's dry and pigmentation. Now, this is actually a hand of a patient with scleroderma. So, scleroderma is there is the tightening of the skin, wala siya wax of hitsura. That is why they appear like tight. There is kanang it's shiny, no? And then because of that, mag-contractures na sila, thus they will have these ulcers. Okay? So, very interesting case. It's really not that common, the scleroderma, especially in children. Okay. This one is another picture of a patient with scleroderma. So, there is already contractures because of the tightening of the skin. This one is also a localized scleroderma. There is already fibrosis in this up part. And then this one is half of the face is already sclerosed. This is also a patient with localized scleroderma. How about this one? Do you think this patient has an autoimmune or a rheumatologic condition? Because of Okay. Now, it is very important that you have to rule out or rule in other possibilities because this patient is actually a patient with vitamin D deficiency. So, di ba, I have mentioned earlier that metabolic or endocrine conditions could be mimickers of rheumatic condition. So, if you see this one, this is what we call the rachitic rosary that we see in rickets, no? So sometimes we will see this might have a rheumatology condition because of the bone abnormality. But there are a lot of conditions that we can think of. It could be metabolic, pwede siya congenital bone problem, no? Especially as kanang young as this one. Okay, so this is not a rheumatology problem. Okay, so this one, I've shown you this one. These are your what? Sa ito kung giingon ninyo ganina. Pathognomonic sign of your JDM.
Gotron papules.
Okay, so these are Gotron papules. This one is the Gotron papules and your calcinosis cutis. This one is the leg length discrepancy. No, if you see the patient is already standing on this kanang block just to have that same height. Aside from the discrepancy in the length, what else can you observe in this picture?
Smaller
The muscles, though.
foot down.
Oh.
Okay, very good. So if you notice in the right leg is smaller than the left, so there is already muscle atrophy or atrophy of disuse because of the arthritis. Now, if you wonder how are we going to address this leg length discrepancy, no? Like when a patient will walk, magkimpang na gyud siya. But there are actually shoes that pwede ka maka-customize wherein the other shoe will have that more thick sole just to kanang iniglakaw niya is dili siya malimp. So, we can do that. In fact, I saw an American in Ayala wherein I noticed his shoe was actually the sole is higher than the other one. So, but I don't know what happened to him. I just saw his shoe. So, but it can be done. Okay. How about this one?
Contraction, doc.
Sato?
Contractures.
Contractures sa hands, no? How about this one? Picture on the left.
Yung
Small
TMJ.
jaw, though.
O sato?
Here's a small jaw, though.
Small jaw. So this is a patient with micrognathia. So micrognathia is there is receding of the mandibular area because of involvement of your TMJ joint. No, it's actually very common in children. You rarely see it in adults. So the micrognathia because of the TMJ involvement. Okay, so let's watch this video. Okay, sorry, longer to siya. So what can you say about the video?
Is that Korea, though?
Korea.
Yeah, so it is Korea. We see that in patients with rheumatic fever. Okay, purposeless movements. And then in rheumatic fever, chorea is usually absent during sleep, and they appear when they are awake. Okay. This one. Okay, so what was that? So that was a maneuver using the milkmaid's grip. I don't know if you have read that one in rheumatic fever, to show na there is uncontrolled movement of the hands, like you are milking a cow, no? That is the milkmaid's grip. You see also that one in patients with rheumatic fever. Try to look at the hands of the girl. Okay, let's move on to this one. Can you hear the conversation?
No,
No, Doc.
Okay, so let's not hear the paano lang. But that one is what? If you know,
Calculations.
tongue fasciculations, or that is what we call the wormian movement of the tongue. So it's like a worm, no? Don't know kung try to see the tongue. Okay. Okay, so that's the wormian movement of the tongue. That's one also procedure to check for kanang uncontrolled movement or chorea. So we have the milkmaid's grip, the wormian movement of the tongue. Some would also like to ask the patient to write their name, and then if there is kanang bati ang agi or uncontrolled movement of the handwriting, that is purposeless movements that we see in rheumatic fever. Okay, let's watch this one. Okay, so what was that? Can someone describe to me the gait of the patient?
Growers, no?
Mhm.
Growers.
Gower sign. Gower sign.
No.
Gower sign is the standing up from sitting position. No? So this one is an example of a proximal muscle weakness. So try to see how he stands up. Then observe how he walks. Okay. Can you observe how he walks? That's what we call the wiggling gait, because of the proximal muscle truncal weakness. The patient walks like a duck, no? So inana siya. And Gower sign is also another sign for muscle weakness, proximal muscle weakness. Okay. This one is the mechanic's hands. Sometimes we do have dry skin, no? So, kana magpaknit-paknit. But in us, we have differential diagnosis for it. So this is the mechanics. Hence, we see that in patients with juvenile dermatomyositis, these are thickened erythematous and scaly rash over the palms and soles along the flexor tendons. This one is lipodystrophy. So some of you might want to go into diet, no, and lose the subcutaneous fat, but you don't want to look like this. So this is a lipodystrophy associated with juvenile dermatomyositis. There is a result of a progressive loss of the subcutaneous fat and visceral fat, typically over the face and upper body. So this lipodystrophy can be generalized or localized. Okay, so what are the clues to the diagnosis? Now, this one table is showing you or categorizing to systemic and localized and acute and chronic. And these are the conditions that you can consider if the patient has a systemic manifestations and the onset is acute or chronic, and if the patient has a localized manifestation and whether it is acute or chronic. Okay. Each clinical entity has its specific diagnostic workup, but here are some general rules. Do not order what you do not want back. This is especially true regarding ANA in a child without arthritis or in whom you do not suspect lupus. Now, up to 30% of children will have a positive ANA test, and subsequent evaluation can lead to unnecessary cost and anxiety, like I have mentioned earlier. And ESR should not be used to confirm diagnosis because in patients with rheumatologic condition, it is basically an inflammatory condition. So you would expect that the ESR will be elevated. So you do not want to get ESR just to diagnose the patient. And rheumatoid factor in pediatric rheumatology is used also not to diagnose, but as a prognostication. So like in patients with juvenile idiopathic arthritis, if the patient will have a rheumatoid factor positive, it will indicate that the course of the arthritis is the same as those in adults with rheumatoid arthritis, which is actually more deforming and more debilitating. Now, radiologic examination is also very important in our diagnostic to support the diagnosis. So one is your ultrasound. It can be used to assess for other periarticular soft tissue abnormalities, including popliteal cysts and other soft tissue masses. Your CT scan will generate a high detailed images of the bone and can evaluate the joint space and detect adjacent bone abnormalities. The good thing about CT scan is it is faster and sedation is generally not required except for young patients. The MRI provides the exquisite multiplanar images with superb tissue contrast. It can define vascular anatomy, often without the need for IV contrast. But the downside of MRI is its high cost, it's expensive, its limited availability, and the frequent need for sedation. But it is the best modality to examine all joint components except the cortical bone, including the bone marrow, hyaline, fibrocartilage, ligaments, meniscus synovium, joint capsule, joint fluid, and the unossified cartilaginous skeleton. Your bone scan, I know you have heard of bone scan. It is a nuclear scanning test to define or identify abnormalities in bone. It can help differentiate osseous causes of joint pain from other causes. And it is used whether an osseous lesion is solitary or multifocal. And if there is inflammation, it will reveal an increased activity on that part of the bone. And then it is also used to diagnose bone cancers and assess bone densitometry. Okay, so this one is a radiograph showing you the joint destruction in a girl with polyarticular GIA, rheumatoid factor positive, and treated with corticosteroids. So this is the baseline X-ray. no? And 4 years after, this is how the hand looked like. So there is already loss of the articular cartilage, destructive changes in the distal and proximal interphalangeal joints. And if you see also, there is already fusion of the carpal bones. As compared to the baseline, makita pa nimo ang each carpal bones, but because of the destructive nature, because it is rheumatoid factor positive, you can already see the fusion. So I can just imagine on physical examination, this patient will have limited wrist flexion and extension. And there are already osteopenic changes now near the joint of the MCPs and PIPs. If you see, mas dili na siya white, like what a bone should normally look like. And then there are already joint space narrowing of the PIPs and the DIPs, no? If you've noticed on this side, na-apply space imong PIP and DIP. But here it is fused already. So you can imagine that these patients already has the flexion contracture. Okay. So this is a cervical picture of a patient with cervical lateral flexion limitation. So if you can see, there's already fusion of your C2 and C3. Okay, so if you have this kind of X-ray, you would expect already limitation of motion of the cervical movement. This one is a hip X-ray showing you the fusion of the hip joint, no? And this one, there is already dislocation or subluxation of the hip joint. Okay. Okay, so now let's move on to SLE. Okay, so I know siguro you have seen these slides of mine, but I will just show you these are the personalities that we know who are suffering from SLE. Okay, so this one is Seal, the singer Seal. So he was famous of this scar on his face. This is actually the discoid scar, no, that we see in SLE. And you also know Ferdinand Marcos, our past president, late past president. He died of lupus nephritis. And this one is, I don't know the name, but he is the husband of Mariah Carey. And then this one is Toni Braxton. If you know Unbreak My Heart song, she has lupus. And the latest we know is Selena Gomez, who has lupus. Okay, so SLE is a chronic systemic autoimmune disease. It is characterized by the presence of autoantibodies directed against self-antigens. Now, the mean age of diagnosis is approximately 11 to 12 years old, and 20% of these are diagnosed before the age of 16 years old. There is a female predominance. I will explain to you why. There is a 2 to 5:1 female to male ratio before puberty. The ratio becomes higher in the reproductive years, being 9:1, and then it returned to near pre-pubertal ratios in the postmenopausal period. Now, more severe and widespread organ involvement are seen in pediatric SLE compared to adults. Now, rare occurrence is seen in less than 5 years old. The true incidence and prevalence of SLE in children is difficult to estimate because there have been very few studies focusing on the pediatric population. But the time to diagnosis of SLE from onset of symptoms can range from 1 month to 5 years. Now, 30 years ago, the reported survival of pediatric SLE at 5 years was 82%. At 10 years is 76%. But because of the advancement of technology and the discovery of new drugs, the 5-year survival rates has reached to more than 95% already at 5 years and 86% at 10 years. So it should be considered as a potential diagnosis in a patient who presents with multi-organ system disease. In fact, it's so surprising that in Soto, because I go there and see their service patients, we really have a lot of patients with SLE. So I don't know why, but yeah. I seldom see SLE patients in private practice. I don't know, maybe because majority of the patients in Cebu are in the low to middle income, so they go to Soto. And then A and A are present in more than 90% of patients with SLE. Now, the pathogenesis of SLE remains unknown, but there are several factors that influence the risk. There is genetic predisposition, it is hormonal, and there is environmental exposures. Now, there is association with specific genetic abnormalities, including congenital deficiencies of your complement, C1q, C2, C4. And because of the finding that individuals with SLE frequently have a family history of SLE or other autoimmune disease. But important also that there are influential risks for SLE like the non-Mendelian genetics and epigenetic. Okay, so it means to say that it occurrence is sporadic in some patients. So hormonal factors have a strong association in women of reproductive age. Why is this so? Because the estrogen, which is higher in females, promotes the B-cell autoreactivity. Because of this, female sex is the strongest risk factor for SLE. In fact, of individuals with SLE, 90% are female, making it the strongest risk factor for SLE. And then since estrogen, we mentioned about estrogen, how about those patients taking estrogen containing oral contraceptives? So are they also at risk for SLE? But they do not appear to induce flares in quiescent SLE, although the risk of flares may be increased in postmenopausal women receiving hormone replacement therapy. And environmental exposures can also trigger SLE, like infection or drugs. I have a patient we recently diagnosed in Soto. It was triggered by using a hair dye because they have an experiment about formulating a hair dye, I think, and then the patient applied it to herself, and then after that, the symptoms appeared. Okay, so that is why I do not encourage my patients to take a lot of medications, especially those who are herbal or even kanang dyeing their hair or putting something on their face because we do not know these drugs could trigger SLE flare. Okay. And then ultraviolet light exposure is a known trigger to SLE disease activity. So that is why I advise patients to wear the sunblock, which is more SPF more than 30, because that's the SPF number that is protective against the sunlight. Or I do advise my patients that they can go to the beach, but they can swim when it's already the sun is already setting down, no, not when the sun is still up, because it can induce flare. Okay, now histologic features suggestive of SLE can be found in renal and skin biopsies. So this is, sorry for the slide, this is a discoid rash, and a discoid rash. These are hyperkeratosis, follicular plugging, and infiltration of mononuclear cells in the dermal epidermal junction. Now, there is what we call the lupus band test. So this is a direct immunofluorescence staining on skin biopsy, demonstrating immunoglobulins and complement components in the dermal epidermal junction. So the one that fluoresces is a positive lupus band test. So this is a direct immunofluorescence of a discoid lupus erythematosus. Okay. Now, lupus band test should be considered positive when deposits of IgM in sun-exposed skin form a continuous band over at least 50% of the width of the biopsy specimen, which is at least moderate in intensity. Now, what's the pathogenesis of SLE? The hallmark is the generation of your autoantibodies, meaning to say your body is producing an antibody against your own. No, it lacks the characteristic of recognizing oneself. Okay, so it is directed against the self antigens, particularly the nucleic acids. Now, also, individuals with SLE have a markedly increased levels of apoptosis. They have increased levels of dying, clearing of the cells, or they have significantly impaired ability to clear cell debris. So if this is the case, the prolonged exposure to nucleic acids because of uh, the cells that are being um, cleared, so in the bloodstream, so they will have the opportunity for their recognition by the immune cells, thereby leading to production of autoantibodies by the B cells. Now, once these circulating autoantibodies, they will form immune complexes and they will deposit in the tissues, it then therefore leading to local complement activation, initiation of pro-inflammatory cascade, and ultimately tissue damage. Now, individuals with SLE frequently demonstrate abnormal cytokine levels or the interferon, promoting expression of other pro-inflammatory cytokines, maturation of monocytes into myeloid dendritic cells, promotion of autoreactive beta and T cells, and the loss of self-tolerance, which is what we call the type 1 interferon signature. Now, important to remember that although SLE is an autoantibody disease, it doesn't involve only the B cells, no? It also involves the T cells. So both B and T cells demonstrate functional impairments in SLE. Why? In B cell populations, they will have impaired tolerance and increased autoreactivity. We know that one. So it enhances the B cell's ability to produce autoantibodies following exposure to the self-antigen nucleic acid. Now, how about the T cell? Increased number of memory T cells and decreased number and function of T regulatory cells, they will display aberrant signaling and increased autoreactivity. And this is also resistant to attrition by the normal apoptotic pathways. Okay. Now, just to summarize that in a patient with SLE, it has to have the risk, genetic susceptibility, there is environmental trigger, and there is immunologic abnormalities. Now, because SLE is systemic, it hits from both, from the head up to the toe. So that is why we are very meticulous with our physical examination findings. No? So the presentation of SLE in childhood or adolescent differs somewhat from that in adults. Arthritis is usually present in the first year of diagnosis. Arthritis may be painful or painless swelling, often with stiffness in the morning, and is usually symmetric polyarthritis. The renal disease in SLE is often asymptomatic, underscoring the need for careful monitoring of the blood pressure and urinalysis. And in SLE, in adolescents, patients can also present with nephrotic syndrome or even renal failure. Okay? The neuropsychiatric manifestations of SLE can occur with or without apparently active SLE. So this poses a difficult diagnostic challenge, especially in adolescents who are already at risk for mood disorders. Now, these are pictures of the manifestations. This is the oral ulcer. This is the malar rash. This is the patient with the malar rash. And aside from that, these patients look depressed. No? So patients with chronic conditions actually have depressive symptoms. And aside from it could be a complication, but sometimes depression is a flare-up manifestation of SLE. So these are the ulcers. These are the vasculitic lesions that we see, no? And then this one, the palms, these are vasculitic rashes, alopecia, and then we have the arthritis. And the arthritis in SLE is non-deforming. It's not like the juvenile idiopathic arthritis, which is deforming. And then these patients will also have the SLE retinopathy. So meaning to say any organ system can be involved. And the most presenting complaints of children include fever, fatigue, hema problems, arthalgia, and arthritis, often characterized by periods of flare and disease quiescence, or may follow a more smoldering disease course. A disease that evolves over time in each affected individual, and new manifestations may arise even many years after diagnosis. Now, there is also what we call the J-code arthritis. We know that arthritis in SLE is non-deforming, but they can have the J-code arthritis. It is a deforming arthritis in SLE because there is laxity in the ligament and the tendon. There is also what we call the lupus. Lupus is a destructive arthritis also associated with a positive rheumatoid factor, but this is rare in children. Okay, what we commonly see in children is development of SLE in a patient with a long-standing definite polyarticular or systemic GA. So meaning to say, a polyarticular or systemic GA can evolve into SLE. Okay. Now, this is a slide showing you the diagnosis. So I will not tackle on this because there is already a newer classification criteria. But just to show you that this is the 1982 ACR revised in 1997. Actually, during my time, this is what we know so far. We have the 1982 revised 1997. So during our med years, we use the mnemonics brain soap MD, dopamine rush, just to memorize this classification criteria. But it has already evolved. In 2012, they released another criteria, which is called the SLIC criteria. This is found actually in your book. So SLIC means Systemic Lupus International Collaborating Clinics classification criteria for SLE. Now, this is the same basically in the original one, the 1982. They just added more variables in this classification criteria because their goal was to catch more probable lupus patients so that they can identify early and manage early. As compared to the ACR or the 1982 revised 1997 criteria, it was more specific, but it's not that sensitive. But in SLIC criteria, the principle is the rule of 4 remains the same, but there is a new principle. There must be at least one clinical and one immunologic criteria, clinical and immunologic criteria. And if there is a lupus nephritis by biopsy in the setting of ANA or anti-double-stranded DNA positivity, then no further criteria is required. In fact, they compared the two, the ACR and the SLIC. So as mentioned earlier, ACR was more specific but not sensitive. The SLIC criteria, they wanted it to be more sensitive, reaching to 97%, but it's not that specific. But they get their goal that they want to catch more probable lupus patients, and it was actually very significant. However, in 2019, they also developed the 2019 ACR EULAR criteria. This is the one we're actually using. This is not still found in your book, but I want you to know this one because when you do your third-year clinics or internship or senior clerkship, you will encounter already this criteria. We no longer use the SLIC and the ACR. Now, in this 2019 criteria, the mandatory criterion is you have to have an ANA positivity, at least 1:80 dilution, okay? And then you have to check for points. So clinical domains and immunologic domains. So how do we classify as patient having with SLE? If there is at least 10 points from this criteria, okay? And the mandatory criterion is a positive ANA, at least 1:80 titer, okay? So this actually in the internet, there is a calculator for this also. Okay, now I'll focus on lupus nephritis because this is the significant cause of morbidity and mortality in children, and it's actually higher in incidence compared to adults. So the most common patterns, we have proliferative, which is class 3 and 4, mesangial, class 2, and membranous class 5. And the pathogenesis of lupus nephritis is the immune complex deposition. So a positive ANA test is present in 95 to 99% of individuals with SLE. It is very sensitive. That's why we usually get ANA to diagnose patients with lupus, but it has a poor specificity test. And important to note, as mentioned earlier, up to 30 or some books will say 20% of healthy individuals will have a positive ANA. But your ANA titers will not reflect disease activity. So meaning to say you will not monitor it or request it again to see if the lupus is gone. No, because if it is positive, it will really be positive and it will not reflect disease activity. Now, antibodies to double-stranded DNA are more specific for SLE, and anti-dsDNA correlate with disease activity, unlike your ANA. Your anti-SM is also specific for SLE, but it does not correlate with activity. Now, your complement levels like CH50, C3, C4, when you have an active disease, they will have a decreased level in active SLE. Now, important to remember also that ESR is elevated in SLE, but CRP does not correlate well with the activity, even if it is an inflammatory marker, because an elevated CRP may reflect infection rather than disease activity. Why is this so? Because in SLE, the pathway for CRP production is actually abnormal at onset na. So you cannot rely CRP to check for disease activity. So when we do request for CRP, we more rely it if the patient is having fever because of an infection rather than disease activity. Okay. Some patients will have antiphospholipid antibodies, which is if you are positive with this, there is an increased clotting risk. And it can be found in up to 66% of children and adolescents with SLE. Now, what are APA's laboratory findings? We have positive anti-cardiolipin or anti-beta-2 glycoprotein antibodies. We have a prolonged phospholipid coagulation test like your partial thromboplastine, DRBBT, and your circulating lupus anticoagulant. Okay. Now, this is also found in your book. These are the autoantibodies that are typically associated with SLE. So you just have to read this one. I have mentioned already anti-dsDNA and anti-sleep. Your anti-RNP is seen in patients with Raynaud's phenomenon or in patients with overlap syndrome or mixed connective tissue disease. Your anti-RA and anti-LA, you will be encountering this one in neonatal lupus because they will be positive, and also in patients with Sjogren's syndrome. And then this one, antiphospholipid antibodies, they have the increased risk for venous and thrombotic events. And the antihistone antibodies are seen in patients with drug-induced lupus. Okay, so how do we manage patients with SLE? So generally, we have to counsel, educate, and it has to be a team approach. We have to remind patients to have adequate rest. So I always tell them just to be relaxed and chill. Do not be overstressed. And important to mention also the appropriate nutrition and vitamin D supplementation and calcium intake. Why? Because these patients will be taking steroids. And you know, based from your pharmacology, that your steroids have an effect on the bones. So you have to supplement this with calcium and vitamin D. And you know, because sunlight will cause a trigger in SLE, you have to advise patients to use the sunscreen. It should be SPF more than 30. And also your immunizations. So written immunization is recommended, including the annual influenza vaccination. Okay? And in addition, patients age 6 or older should receive an additional pneumococcal 13 vaccination, followed by pneumococcal 23 at least 2 months later. But live vaccines are contraindicated. Okay? And then because, of course, we have to prompt management of the infection because it will trigger also an infection. And because pediatric patients also are at high risk for developing anxiety and depression, screening for depression is also essential. Peer support and cognitive behavioral therapy intervention will reduce pain and enhance resilience in patients with SLE. And also, it should be remembered that pregnancy can worsen SLE, and obstetric complications are very common, especially in a young child and the more with SLE. So many medications also used to treat SLE are teratogenic. So it is important to counsel adolescent girls about these risks and facilitate access to appropriate contraceptive options. Now, hydroxychloroquine is recommended throughout the pregnancy. It is actually a safe drug for pregnant women with SLE. But you have to watch out for potential toxicities of hydroxychloroquine. If you can remember your pharma, there is retinal deposition and vision impairment of in the use of hydroxychloroquine. So we recommend this patients who have an annual ophthalmology exams for those who are taking hydroxychloroquine. Okay, and then because of the risk that ocular toxicity, including the duration of the use and dose of hydroxychloroquine, it is never prescribed at a dose of more than 6.5 milligrams per kilogram. So a maximum dose is 400 milligrams daily. And newer OPTA guidelines already recommending the dose at 4 to 5 milligram per kilogram. Okay. Now, corticosteroids are a treatment mainstay for significant manifestations of SLE, and it works quickly to improve acute deterioration. But important to note that steroids also has side effects. No, you have learned this in pharma, and this often limits the adherence of the patient to the drugs, especially in adolescent patients, wherein they are more worried about the toxicities because they will look fat, they will have pimples and things like that. So that's why I mentioned here the adverse effects of corticosteroids. We have growth disturbance. Patients will have weight gain, striae, acne, hyperglycemia, hypertension, cataract formation, vascular necrosis, and osteoporosis. So cyclophosphamide is another drug that is administered intravenously. So we know this one, it is reserved for the most severe, potentially life-threatening SLE manifestations, such as renal, neurologic, and cardiopulmonary disease. Now, potential toxicities of cyclo, we have cytopenias, infection, hemorrhagic cystitis, premature gonadal failure, increased risk of malignancy. So because these patients will have the hemorrhagic cystitis, adequate hydration is needed to attenuate the risk. And what we know in pharmacology, we know that cyclophosphamide is divided into two, the active component. The acrolein part, which is the part of the cyclophosphamide component, is the one that is causing the hemorrhagic cystitis because it is not soluble. So it becomes an irritant to the bladder. That's why they will have the cross bloody urine. So in order to reverse that, we have to have adequate hydration. We have to give adequate hydration to the patient. And then because of the fear of premature gonadal failure, it is important to note that young girls who are pre-pubertal are much lower risk of gonadal failure compared to older women. And there are already drugs like leuprolide acetate, which is a gonadotropin RH agonist. It helps prevent the gonadal failure. So SLE patients with APAS syndrome, so they are treated with long-term anticoagulation to prevent thrombotic events. For SLE patients who are APAS positive without a history of clot, many pediatric rheumatologists prescribe aspirin 81 milligrams daily. So the complications and the most common cause of death in SLE are infection and complications of glomerulonephritis and neuropsychiatric disease. The long-term complications of SLE and its therapy include accelerated atherosclerosis and osteoporosis. There is also increased malignancy rates because it may be caused by immune dysregulation as well as exposure to medications with carcinogenic potential. So this is my last slide. The severity of pediatric SLE is notably worse than the typical course for adult onset SLE. So advances in the diagnosis and treatment of SLE has improved the survival dramatically over the past 50 years. And given the complex and chronic nature of SLE, it is optimal for children and adolescents with SLE to be treated by pediatric rheumatologists in a multidisciplinary clinic with access to a full complement pediatric subspecialist. Okay, thank you. So sorry, I have to talk fast. So I think that's it. I don't have time already to talk to you about a lot of rheumatic conditions, but if you want to learn, you can just kind of message me and I will talk I will be happy to talk about it to you. Okay?
Yes, Doc.
Okay.
Doc.
See you. Thank you.
Thank you, Doc.
Good job.
Thank you.
Thank you,
Doc.
Doc.
Thank you, Doc.
Okay.
Thank you, Doc.
Good job.
Good luck.
Thank you, Doc.